I'm getting a whiff of this. Let's put this on the table. Are there people sitting in a basement with a green eye shade somewhere saying, you only had 14 attacks, you can't get this? Is there someone in some company somewhere really doing
There
that?
is not in my health plan. And I think, the prior auth process, I think, gets a bad rap because of its onerous and the paperwork. But in fact, what is good about it is you actually have an educated human, a specialist who knows something about the topic, reading through the clinical notes and helping to make the right decision. So there is a human at the end of it, and that's the good point.
I would like to add that there are some insurance plans, Blue Cross, Blue Shield subsidiaries in Florida, Pennsylvania, and Kansas, who are requiring that patients, before they get this drug, that it be prescribed by a UCNS certified physician. There are only 520, I believe, UCNS headache specialist, certified headache specialist in the U.S. There are, as you mentioned, are millions of people with migraine. So, and on top of this, in Kansas, there are no UCNS certified physicians. So I think insurance companies run the risk of creating care deserts by doing this. I see a headache specialist, and I can tell you that he's on fluid restrictions during the day because he doesn't have time to take a break because he is really, really busy. And most headache specialists I know say are the same.
I'm going to dismiss this image of fluid restriction because you can't take a break from my mind.
Okay.
I can't unthink it, I'm afraid, but that's terrible.
Well, I'm a nurse, so
But I
go there.
Are you ascribing, and I'll just put you on the hook here, are you ascribing to these folks some nefarious motive? We're going to put a clamp on the pipeline by restricting the number of prescribers.
Yes,
Okay.
I am.
So, your plan may not do that.
No.
But other plans out there are. What do you think of your colleagues?
From what it sounds like, that sounds like an unreasonable barrier to care, actually, given the access issues that you've described. And I do think that where I live as well, there are access issues that I do think are going to create barriers for patients, and even like I said, access to primary care, but access to specialty care for sure. I mean, even though we have plenty in California, it's not always easy to get in, and so people are having to wait, and that is a real problem, I think, for all of us to help solve. It's not something that one person can do, but certainly those types of restrictions that say only this person can prescribe it, we're not bending on that. That seems a little bit restrictive.
Yes.
All right, let me play devil's advocate. I like doing that. Yes. Now I'll switch hats. All right, I'll put on a green eye shade. Be an angel. No, maybe not. I'll put on my green eye shade, those little things that go on your arm, when you look through paper, and say, unless we do that, we're going to bankrupt America. Everybody's got a new biologic they want for their disease.
I have a response to that.
Oh, please, let me hear it.
Yes. Having migraine disease is expensive. It's expensive for insurers, but it's also expensive for people who suffer from the disease. There are the direct costs that come with having migraine, but there are many, many indirect costs, such as having to work part-time because you can't work full-time, having to quit your job, go on disability, not having the capacity to care for yourself at home, having to hire people to cook your meals and do your housework. It's and the expense of the medications.
All right, let me be my little green eye shade. This analogy is getting a little old, but I'll come back at you and say, not my silo.
No.
My silo is this healthcare plan has this many dollars, and I can allocate it this way. Society has other issues, but it's not my silo. Nobody is paying me more because society is losing money on migraines. How do you fix that, patient advocate?
You have the person spend a day with the person having a migraine.
Good luck on that.
Because it's disabling.
I hear you. But again, as long as it doesn't impact my budget.
Right. Well, I'll jump in.
Oh, yes.
I'll help you out here.
Thank you.
So,
Gang up on me, come on.
as a plan, we of course partner with employers because, folks who have migraines tend to be in the productive years of life, right?
Yes.
And so it's a big issue for employers, missed days, and
Exactly.
we are selling our product to employers who need coverage for their employees. So that's exactly the kind of thing where we can come together, I think, and talk about this. And we do, actually, to say, hey, you know, on the employer side, how can you know, help take care of your employees so they don't have this? How can we work together? You know, how can we make this easier?
The dominant demographic of migraine is from the age of 20 to 60. They're the people who are working and paying your little man with the green thing his income.
Could be a woman.
That's well.
Could be a woman with a green thing.
I thought that I took you to be a man at the time,
Well,
but
yeah.
nevertheless, it's the dominant demographic. It's the people who are active in the plan. Of course, the other thing to say is that attending an emergency room with migraine is an appalling waste of resources. It's bad for the patient. It's bad medicine from my perspective when I see it happen to my patients, and it doesn't help the bottom line either, because tests get done. People come in with a horrible headache, they have a bit of neck stiffness. So they get all of the tests done again and again and again.
I'll bet they
Total
all
waste of
get-
resources.
They all get CTs, don't
Yes,
they?
exactly.
Or MRIs.
Or MRIs.
Or MR, yeah.